considerations in otoplasty are understanding the spectrum of non-microtial deformities, common anatomic deformities they share, analyzing each deformity, recognizing we may see different deformities on each side, and really understanding how each technique or maneuver affects the specific anatomic changes we're trying to accomplish. There's been a lot written about so-called cartilage-sparing techniques that's all trying to do everything with suture placement alone. And really, in many respects, it's more difficult to force cartilage into an altered shape or position than it is to selectively resect cartilage or add cartilage grafts to change the shape. When you look at non-microtial deformities, the ones most significant are the prominent ear, constricted ear, cryptotia, Stahl's ear. And understanding how the similarities in some of those deformities can be approached, and it really opens up the whole field of how to fix these problems. And it's really not so important what you're calling it, it's just understanding really all those things involve some degree of upper pole deformities. And I'll try and show that to you through a number of cases. We pay very little attention to one another's ears if they're the right relationship and size to facial features, but few deformities excite as much ridicule as ears, and even small deformities can be the source of significant psychological distress. Normal ear proportions have all been written about, and anthropomorphic studies show exactly angles and distances from the head, but we really innately see what looks normal in terms of size, in relation to the facial structures, projection, and those are much more important parts of putting things in the right place than the measurement. But from earliest years, even minor deformities like this trifurcated collarbone of the ear can cause significant distress. When I first saw him, he pretty much was in tears. He had difficulty in school. And fixing something like this can change their whole approach to how they feel and how they deal with other kids very quickly. Often we see grandparents or parents who had similar deformities but never had them treated, bringing their kids in so they don't have to deal with the same stresses that they went through. And even minor deformities like this crimping of the upper ear, a form of constricted ear, really, for him, he was very successful, but the change in that was just as important to him later on as it was to a young child. So we should try and plan surgery to minimize psychological trauma, or we can make the decision to wait till they express their concern. But even young kids, a 4-year-old, she was able to point out in her drawing, although it's a mirror image, a very small little nubbin of tissue, and the love part was her saying, you know, she called Dr. Bauer, who's going to fix my ears. Changes in style, increased activities that require hair out of the way brings a number of adult patients to otoplasty. Prominent ears are the most common things we deal with, but the whole spectrum of deformities in shape, size, projection, balance of the ear with facial structure can be corrected. And the key to correction of these deformities is correctly analyzing the abnormal features and selectively placing a surgical approach that deals with those specific things. By 5 years of age, the ear is structurally ready to go through the changes and maintain the shape. Child generally can cooperate at that point. For prominent ears, a lot has been written about the different features. Deficient antihelical fold, conical hypertrophy was always kind of put on the bottom. Anatomic deformities in the underlying skeleton can push the ear out from the side of the head. Isolated lobular hypertrophy and macrotia. Each deformity differs in cause, and you can see totally different things on the two sides. And even though we recognize it more in the microtias and in significant hemifacial microsomia, asymmetrical head, particularly with uncorrected plagiocephaly, will often be the cause of the ear being pushed out in the unilateral deformity. We have to address that slightly differently. Most common complaints of leading to revision of otoplasty: sharp antihelical fold, overcorrection, pin back look. Undercorrection is much easier to deal with. It's fairly a failure to original assessment of the patient. And overcorrection, the antihelical fold, either through scoring or just suture placement, is often a source of patient coming for revision. And this was an early patient and looked at, he had prominent ears, but you can see how nicely his antihelical fold is formed. It's the concha which is pushing the ear out from the side of the head. He was treated by sharpening the antihelical fold further, and then when he went for revision, further sharpening the antihelical fold, and really was not addressing the concha at all. So what we called a combined otoplasty technique, I had chondrocutaneous conchal resection as the cornerstone of the procedure. As soon as you cut through the concha and you do it through an anterior approach, it softens the whole ability and eases the ability to change the shape of the antihelix without any possibility of irregular folds or sharpening of the and irregularity of cartilage that comes with scoring techniques. Here, just very briefly showing the incisions placed where the shadow changes in the concha, incision carried through the skin and cartilage, and then with gentle pressure on the ear, the amount of skin and cartilage resected, with always removing more cartilage than skin. The sharpness of the angle between the antitragus and the conchal floor, the sharper that angle, the more the lower pole of the ear and the earlobe is tipped up, so when you go across that line, your incision, it breaks the spring and allows your cartilage and earlobe to drop down just with manipulating the skin posteriorly. So the anterior incision is closed, the cartilage is approximated with the 5-0 clear nylon. The skin excision is carried out later in this little squid-shaped excision. How those points come together, whether it's A prime to A, B, or not typically C, once you've broken the spring in the cartilage, will change the shape of the lobule and the projection, so that will set the final position. But once you've done your conchal resection, even if it's small, a few sutures from helical sulcus or scapha and triangular fossa to temporal fascia is all that's needed to shape the ear. You can refine this further by trimming prominent antitragus or Darwin's tubercles just directly. Otoplasty dressing, just a few cases, and even though you're doing resection of skin posteriorly, you do not lose the posterolateral sulcus, which some people have suggested you do with any resection. And you just get a nice soft appearance. I like to be able to see the antihelical fold or the helical rim from anteriorly. She finally got her grandfather to come back. He had a couple of unsuccessful prior attempts at fixing his ears. And he came back ultimately to have his correction. Very proud to be my oldest patient. When you see the one ear tipped out more, in fact, in this post-op, his upper pole really could be even a little closer and tighter to the head. You need to do that to really put the ear in what visually we see is closer to the other side, just because the skeletal base that it's sitting on is still tipping it outward. As you move on to the upper pole ear deformities, this whole host of other deformities have in common some adherence to the helical rim deformity, the scapha, fibrous adhesions of the cartilage, their varying degrees of skin cartilage envelope deficiency, and they may or may not have prominence. If we kind of see what they all have in common, starting with constricted ear, really what we know is that there is some degree of skin deficiency. But you have to make a decision. Are you trying, if it's a unilateral deformity, you're trying to match the normal size of the other ear, or are you just trying to get symmetry between the two sides and change the shape? So for ears that are symmetrically sized, you can do the same kind of combined otoplasty approach and correct that. But most of the techniques for constricted ear fell short in terms of being able to correct it. Because even though it was recognized that the skin envelope was narrow or constricted and less skin than you needed, almost all the approaches were done through a posterior approach, lifting the skin off of the cartilage, skeletonizing it, then trying to change the shape of the cartilage and put that same skin back. If you do that, the skin cannot open up to the change in the shape that you've created with the cartilage. So the key to correction is to go anteriorly along the future line of the helical rim, dissect out the cartilage, release adhesions, splint it into a normal shape with cartilage graft, conchoid cartilage graft, either ipsilateral or bilateral if it's a unilateral, and then redraping the skin. Once you've made that incision in the right place, the skin will accommodate to the increased size. In a very minor deformity here, you can see we're just drawing a line along where the rim needs to be, dissecting free the adhesions that cause this crimping, using the graft as a batten to hold it open, because if you just release the adhesions, it won't stay in that position as much of a correction as you need, and the incision ends up along the helical rim where it's hard to see. Here, it's a more folded or crimped ear. You can separating everything, putting it in the right place, correcting the pointing of the ear in the process, and rounding out the shape of the ear. Just the next step further, a little more constriction, separate the pieces. This isn't a banner flap, it's using the pieces the best way suited for them to be reshaped. And then usually the lidding can be used as an additional graft along with conical cartilage. Reshaping, quilting the skin back into place. That crimp is what causes the upper rim here to tip forward, as well as the short skin envelope. You gain the additional height and create a normal shape to the upper pole of the ear. Another, just a little bit more significantly constricted. The same approach works for the cryptocias and the also the Stahl's ears. So very quickly, cryptocia, you need to create the superior antihelical fold. In addition, but to release adhesions both posterior and anterior, the ear comes up. You put your graft in to hold it in place, and you restore the normal height and create the sulcus. And then last, with the Stahl's ear, best fixed actually with splinting early on, but here's kind of a Stahl's variant. Create the roundness of the shape, correct the prominent ear on the opposite side. And here, the Stahl's variant, where the ear is elongated and pointed as a result of that, you really have to shape the rim, so you do expose it. I lowered or mid-pole of the antihelix in order to show more of the helical rim from the front view. And then, in her case, reduce the radius of curve, create the roundness of the ear. So, the conch is the answer. It's the best way of understanding what really happens, and as you start to dissect these out and start to do all these types of maneuvers, you better understand how anything can be fixed of the varied deformities that we see. And it's the skin envelope which really predicts where everything else is going to go. After that, understanding the common themes allows you to fix the whole spectrum of deformities and also to avoid unfavorable result in the repair. And just for one more second, I couldn't help but do it. Just came back from Antarctica. We were down in Ushuaia, and they made a big deal about the prison they had, and the most famous of the killers that they had in the jail. His name was Santos Godina. He started killing at 8, and went by the name Big-Eared Short Man. And obviously, had a lot of stress early on in life. Actually tried to do an otoplasty on him once he was in prison, but it was kind of after the fact. He already killed 22 people.
Hopefully not one of the doctors. Thank you. The next subject is microtia autologous reconstruction, and Jim Lehman will be giving this talk.
Thanks, Steve. I have no disclosures, except there are tickets available for the Indians games tonight. Baltimore. I note that you are anxious to have a ticket, so I can arrange for you. So I'm going to present my experience over 41 years about autologous ear reconstruction and how I got where I ended up getting. So ear deformities are congenital and traumatic. And if you go and look at the history, here in the late 40s, took diced cartilage and put them in Vitalium molds, and then took the mass that he had and put it where the ear was supposed to end up, and the results weren't very good because there wasn't much stability. Radford Tanzer from Dartmouth in the late 50s did total reconstruction using rib cartilage and had pretty nice results, but he didn't really stress that you need a certain amount of vertical height to get good contour. It was really Bert Brent in the 80s who came and taught people how to do a good ear reconstruction using cartilage that you carved, and you needed to practice a little bit before you got into this. And then recently, Nagata in the 90s has taken Brent's work and reduced the number of stages and added cartilage to the superior and inferior cruce, and he has very superb results as well. So if we look at congenital, we look at the classification, anosia, meaning no ear, complete hypoplasia with atresia of the ear canal, without atresia, hypoplasia of the middle third of the ear, hypoplasia of the superior third, and sort of the things that Bruce just talked about, and then prominent ear. Here's an example of a lobular, a conchal, and a true anosia. And that's the only anosia that I ever had in 40 years, so they're not very common. If we look at the incidence, Japanese and American Indians have a high incidence, 1 in 2,000. American Caucasians are low, 1 in 1,500, 1 in 15,000, excuse me. 90% are unilateral, 2 to 1 male-female, and 50% have a mandibular deformity somewhat similar to this. Bert had steps in his total ear reconstruction spread over a year, but there were basically 4 stages. First, the framework, then the earlobe transposition, then elevate the framework, and then the tragus reconstruction. Nagata combined stages 1, 2, and 4, had more intricate framework carving. The 3 points to measure, which are important from the positioning standpoint, are the distance from the lateral canthus, the slant of the nose, and the position of the earlobe. So if you look at these, the slant of the nose in figure A, you can see you want to have the angle of the inset of your ear parallel to that. You look at the distance from the lateral canthus to the start of the ear as distance X. You want to have that lined up. And then you'd like the height of the ear and the lobule to be somewhat equal to the opposite side, so you don't have a significant difference when you're looking at somebody on a frontal view. So making the cartilage framework. It would be nice if we could do this, and maybe in the future with a 3D printer we can do it. Carving the cartilage is an art, you got to work at it. Nagata's technique is a little different than Bert Brent's, but you still have to get the framework, and adding the little piece here gives you a little more vertical height, which is very important in the detailing. And then Nagata's work with the extra piece laid here, and then the trays. So here's a couple examples of my carving. The one on the left, the cruce helix isn't far enough. This one's a much better one. And back in history, there's Bert Brent. That actually is me. Like Mike Parker and 2 of our residents. So time has its way of making its inroads on you. So here's one of my early cases, lobular. Here's the first step. The lobule shifted, and there he is elevated. The symmetry here is pretty close. here's a later result and final here, but here she is 2 years later comparing the right and left ears. So there's a reasonably good match, and it's always nice to see an earring in place. Elevation. Basically, this was Bert's technique, elevate the ear, put a skin graft in. I think it's better if you save a piece of cartilage and then put it in there and cover it with a little periosteal flap and a skin graft, and you'll get a better preserving of the elevation. And then Nagata used the temporal fascial flap, which I think is a lot of extra work and sacrifices the one backup that you have if you have a problem with your ear. So I think that's not something that I ever advocated. So here's the elevation. The key thing is get your flap down so your hair is down where it should be and you don't see skin graft. If you're seeing skin graft, that's not a good result. Tragus reconstruction, the cartilage and skin can be taken from the opposite ear, which gives you a plus because you can set the opposite ear back. And here's a completed tragus and a 20-year follow-up. Another patient with a reconstruction and